Good morning, tribe. Today we're talking to Tammy about nursing in the OR and Pacu setting. As you can tell, I'm a little chilly. I hope you're enjoying the weather wherever you're at. And hi, Tammy. Good morning.
Hi, good morning.
All right, so we got a ton of interest from the tribe about nursing in the OR and PACU setting. We had questions all across the board, and you were generous enough to offer your expertise in both areas, so that's exciting. What did you do prior to your surgical job that helped you prepare for surgery?
So I actually went into surgery straight out of nursing school.
Okay.
Prior to that, I worked in the lab. That was my background. So when I was trying to decide what I wanted to do, I remembered that I worked with patients, multiple patients, but for short periods of time. And so I really enjoyed that. So I was like, okay, well, what specialty would I have multiple patients for short periods of time where I can help more people throughout my shift? And so OR was one of them. So.
Okay, did you do any rotations in nursing school or anything that gave you insight as to what that was going to look like?
Believe it or not, no, I didn't. The most that I had as far as OR's information was we worked a lot with sterility and sterile field. So that was one thing that really helped that I had heard before. We're in nursing school. We know how to set up sterile field for catheters, but not necessarily a table or how to gown up and things like that. And my school did prepare me for that.
Okay, great. Those of you who are tuning in, welcome. We're glad you're here. Feel free to ask questions and interact as you desire, and I will get to your questions as they're appropriate within our discussion, okay? So is this a good place for a new grad to start, in your opinion?
So I look at it two ways. I feel that a new grad can start perfectly well in the OR, but it is a very specific specialty. So I would recommend that if you've been exposed to the OR, like say you were a surgical scrub tech, or you've worked in the OR and see how it is, and you know that that's exactly what you want to do, I would recommend going for it right away. If you didn't have any experience, I recommend starting off getting a good foundation with different morbidities and skill sets, so that way it's you have that foundation and that background, and then go into OR. But there's nothing that I would say, not this acuity wise, but I feel like it definitely is somewhere that a new grad could start for sure.
Okay, good. A viewer, Jennifer, says, "Oh my gosh, Tammy." So a specific question from the tribe previously on the event page, she said, "What steps should I take as a new grad transitioning from behavioral health to PACU?"
Behavioral health to PACU. I would, first off, I would see what type of surgery center you want to work in. So are you going to work in a level 1 trauma, or are you going to work in more of a day surgery type of setting? Because it can vary quite significantly. Where I worked in a smaller hospital. So we did ortho, gyno, general, ENT. We did pediatric dental work. So we had a lot of those surgeries. But if you work in, say, like a trauma hospital, you're going to have, I would say, more of a higher acuity, and you'll have a lot more equipment that you'd want to familiarize yourself with. So if you're transitioning from behavioral health, I think you have a good foundation in assessments, because PACU, that's very critical, is your assessment of the patient. How is their airway? How are their hemodynamics? Your assessment skills you pick up right away. So I think those, and then learning the equipment and skill set that you have in that particular would be good.
Okay, good. Viewers, I just want to say, if you're having any sound issues, let us know, and let us know whose end it's on, because it will depend on which one of us needs to make volume corrections. So if you're having auditory issues, please let us know via the comments. Okay, so are there, the hours, what are the hours like?
So that also can vary as well. Mainly for surgeries, you're either going to have the 5/8 or 4/10. I have heard that some centers do offer 12-hour shifts, but I think that's kind of rare for surgery. You also do have to do on call. So if the surgical center plans the surgeries, you have them within these hours, but of course you have some higher acuity or unexpected surgeries that would have to be done right away throughout the night.
Okay, yeah, that makes sense. Are there any certifications that are specific to OR or PACU?
There is. There are a lot of, so starting with OR, there is the specific one for OR. And I believe you can get that after 2 years and 2 years of OR experience. I think it's a pretty thorough test. There's a few people I work with that were certified. And then also with PACU, a lot of them have their critical care certifications because of it being a critical care area. I think most people try to go that route.
Yeah, that sounds completely applicable. So what characteristics do you think makes a good surgical nurse? And I don't know if there's differences in OR versus PACU, but what makes a good, strong OR nurse or PACU nurse?
Sure. So good characteristics are being flexible, really good time management, communication skills are huge. And the reason, so starting off with communication, so you're kind of the liaison for all different specialties. So you're working with anesthesiology, so anesthesiologists, CRNAs, you work with the surgeons, you also have your surgical scrub techs. You're also communicating with the family. So if you need to do any updates, you'll be updating the family. And then you're also going to be transferring patients with PACU. So you've got PACU nurses that you'll be working with. So, and then also too, before the surgery starts, you go and you interview the patient. So you'll need to talk to the patient and their family during that time as well. And how you would communicate with them in the situation can vary. So being well versed in different types of communication is really, really important. Time management, because so you stop the surgeries with your timeouts. So when the patient comes in, you do a timeout. When you're counting at the end, you do timeouts. And then also, so you have that part, and then you have to make sure that the patient's ready to be brought back. So you have to interview them. You have to make sure that any medications that need to be given preoperatively have been given. You do a timeout there, and then you bring them back. And then also prior to doing that, you also have to communicate with your surgical scrub tech, anesthesia, and make sure that everything's ready. Because you don't want to bring a patient back if your surgical scrub tech is still setting up all their instruments. So, and same thing, if anesthesia is not present, you don't want to bring a patient back. So yeah, really good communication and time management. And sometimes it can be difficult because you might have someone getting something, or they're not ready with their tools, and or just different reasons why something might not be set up or available. So it can get a little hectic with that. So again, and also communicating with them, that kind of makes it like a full circle. Kind of how the process works when you are like kind of start to finish. So you have your patient in pre-op, and your pre-op nurses will get them ready, assess them. Usually we'll be giving the preoperative medications. And then you go and you'll interview the patients, make sure that they meet criteria, if they're NPO, allergies, things like that. And then you'll go back, make sure that you can help your surgical scrub tech set up tools or the instruments, make sure that you have your intraoperative medications ready, make sure that anesthesia is ready, that they have everything that they need, that the room's set up correctly, you have the equipment for that surgery, because some rooms don't have everything that you need for that surgery, because you're doing gynecology, ortho, all these different things. So you might need to move some more equipment into that particular room. So then once you get the green light from everybody, and that's how I would do, is I would check with everybody. Is everybody good? So we know that we're going to bring this patient back. So then you and anesthesia will go and do timeouts, bring the patient back. That's when they're wheeled in. You help with intubation, also getting them over to the OR table. making sure everything's set up. Surgeons come in, they scrub in, sterile field is set up, another time out, and then you'll go, then the surgery starts, and everything goes through with that. Then at the end, you're going to prep Pacu to let them know that you've got someone coming out, and you'll help with the.
While the surgery is going on, what are you as the nurse doing?
So at that point, you are assisting basically everybody in that room and what they need. So if there's another tool that they didn't anticipate that they needed, you're going to go get that. You're going to be charting. You're going to be observing the surgery and making sure that sterile field isn't broken. If there is anything that needs to be mentioned, you're going to be the one to address it. If anesthesia needs anything, you assist with that. And yeah, and you basically watch the flow and make sure that everything's going okay.
So when you say you're charting, you can't physically do hands-on assessments. So and they're primarily draped with sterile drape, right? Mm-hmm. So what exactly are you charting?
You're charting, so the time that it starts, the medication that's being used, the equipment. Let's see, what other stuff do you chart? Also, like a charge capture, you can chart in that. It's typically that when you have, sometimes you have surgical or reps from surgical companies, they'll come in and you'll have to enter in the instruments that were used. If, like, say if it's an ortho, if there's a type of screw that was put in, you need to put lot numbers, date, expiration. So that way it's kind of tracing if there were any complications, they can say this particular equipment there was an error or there was something wrong with that, and we can trace back to the lot number to this equipment.
Sure.
Also the medications that were used, what other things do
So that's on you, not on anesthesia. That's on you as the nurse. You're charting that stuff.
I'm sorry, say that again?
So the meds, you're charting that stuff for anesthesia, essentially?
Actually, so there's going to be the meds. So anesthesia is set up in their own little area. And for the anesthesia medications that are used, we'll chart that. We chart the medications that are used like at the surgical site. So bupivacaine, things like that, the local NSAIDs is what we would chart. Sometimes you have pretty standard ones like the numbing medications, but then whatever the preferences of the surgeon, then you get that right.
Okay, cool. Thanks for clarifying. And then I don't know if you want to add in this answer to this question now before you move on to your transition over to Pacu, but the question was, during a surgery, if a complication arises, what will your role be? So you can answer that now, or you can answer it after you're done with your scenario there.
Sure, I can answer it now. So basically, you are going to be helping anesthesia. So the most kind of critical times of the surgery are at the very beginning and at the end, coinciding with intubation and extubation, and also making sure that before the incision starts, that everything is ready. So a lot of the times, the complications you might have are going to be related to airways. And so there'll be times during intubation where anesthesia has already assessed the patient, but once you actually get in there, it's difficult to intubate. So you're going to be right there with anesthesia, you're helping them, and then if something, at that point, if something happens, you and anesthesia can work together. They'll either not go forward with the surgery or get the equipment needed to have a successful intubation. If it's at the end, you're essentially going to be doing the same thing, but depending on kind of what the issue is, again, you're just really going to be with anesthesia the whole way. You might have some additional help at the end because you don't need to maintain sterile field, so your surgical scrub tech can call Pacu, because normally you would be the one who's letting Pacu know that this is, we're coming out. We're coming. So, but if it's in an emergency situation, you're right there with anesthesia, you're helping maintain the airway, so you could have help from your surgical scrub tech to inform Pacu. There's also been some instances where the anesthesia provider knew that there would be some difficulty with the airway. So then as the nurse, I called Pacu and said, hey, can you get the nebulizer ready? Can you get these medications ready? Because we're potentially going to have this problem. And so you can prepare.
And if it's post-surgery and the sterile field is no longer an issue, do you step in and do the compressions, or is that generally the other team?
So if you say, so I'm mainly focusing, say, on airway, but if you are having a cardiac issue, then yes, you can. If you do not need to maintain sterile fields, then yes, you're going to be doing compressions. And luckily, I have not had an issue during the middle of a surgery where something was going wrong. So I can't really speak to that. But I have had instances at the end we've had to move really fast to get to Pacu. We had to stay in the OR a little bit longer to get them stable enough to even transport them over. And then, but yes, if you're in Pacu, then yes, you're going to be chest compression, ALS, you're going to follow that. The anesthesia provider say that the complications will stay with you until the patient is stable enough to be maintained. What's really cool that I love about surgical services is like you have everybody around you all the time. So you have RNAs, anesthesia, and if there is a code, anesthesia runs the code. They have the medications, regular ambu bags are always right by. You have all of this already available, but they do run the code in OR and in Pacu if they're there. So yeah.
Pretty controlled setting for the most part, right?
It is, yeah. And you know, I was really fortunate enough to work with some great anesthesia providers and great coworkers where we really didn't have a lot of issues. The main issues kind of transitioning to Pacu that you would have are, again, airway. Some people, and especially we worked with all ages. So we worked with children to elderly. I think the age range I worked with was like, I want to say 16 months to like 90 something years old. So I mean, you have a long range of patients. And so there's some issues that are particular to an age range. So like children sometimes have more of vasospasms that they can have. What other issues? Hemodynamics. Sometimes people come out and they're really hypotensive after surgery due to the medications and the type of surgery that they had. So yeah, there have been some codes that we've had, but a lot of airway issues where we have to be bagging people.
Okay, so what would you say the top 3 challenges are as a nurse in the OR or Pacu? You can speak to both if you'd like. And how did you overcome those?
So with mine being probably not a traditional way of going into the OR, because there usually are programs where people will be in a 6-month program prior to kind of being in the OR. Pacu, they can also have that as well, but I feel like it's more, I've seen it more often specifically to OR, where they would have that training program. So some of the challenges I would say is learning the environment and the instruments in regards to instrumentation. Because in nursing school, they don't teach you really anything about the instruments that are used in the OR. So unless you have taken a course on the instruments, you're going to be like, oh, okay, let's see what this is. And that actually, I have relied a lot on surgical scrub techs because they are amazing with instrumentation. And if there wasn't something that I knew, I would give them this book and they're like, oh, it's over here. Or, oh, it's this. I'm like, because I would be running and going, get that. They would even sometimes be like, it looks like this. And it's on this shelf on the left and this. They knew where it was. They knew what it looked like. It was amazing. So, oh my gosh, they saved my butt more times than I can count.
Yeah.
So definitely instrumentation. Knowing sterile field and keeping sterility can be a challenge for some. you know, because it's just new.
Mm-hmm.
And I would say learning about the OR culture is really important because when you're going into it, you really want to know what type of surgeries am I dealing with? What am I going to be working with? Is it only ortho? Is it general? Is it ENT? You want to know so that way you can best prepare yourself. Be familiar on what that type of surgery entails. So I think having that background of that culture, understanding who you work with, what your role is, like those are big things that you want to make sure that you learn. That can be challenging, but you learn. And then also time management. Make sure that you know your time management. And again, that sometimes can be challenging because you have, in that area, sometimes you have a lot of variables that can come into play, like patient's not in PO. Okay, now I need to readjust everything that I just did because we might not be doing this surgery. Or there might be a complication in the OR. You have to adjust for that and managing your time. So yeah, I think something like that.
Good. So I feel like you kind of already went over this, but I'm going to ask it just in case you have something else you want to interject. And then a student asked a little bit of a question at the end of this. So what does a typical day look like? What are your actual duties? A student nurse did a rotation, said the nurse and I the nurse I was with only helped upset the sterile field and counted gauze and instruments.
Mm-hmm. So the typical day I think I did kind of mention that about, I can go through it again if you'd like, but basically go see the patients, or I'm sorry.
Yeah, no, I think anything else you would add to clarify her question in terms of her experience as a student nurse? It's probably more involved when you have the responsibilities yourself.
It is, and I can understand, and I've heard that a few times where people, they're like, well, I just saw the nurse sitting and instruments. Is that all that you do? No, we do a lot more than that. But I can understand if you are observing, that is what it can look like that. So it can vary because some surgeries are more challenging than others, and some surgeries are more intricate. So as far as what you'll need, it just really can vary. But ultimately, you are there to support everybody so that the surgery goes well. That's kind of how I look at it. What can I do to make sure that to facilitate this and that it goes well and that it's safe for the patient? Kind of a textbook definition is you are an advocate for the patient because they cannot advocate for themselves. They are completely unconscious. And you have anesthesia typically at the head of the patient because they're monitoring everything and they can administer medications. And then you have the surgeon and the scrub techs who are on the side, and you are outside of the sterile area, sterile field. So that way you can help facilitate and make sure that everything goes smoothly in whatever way possible, whether it's getting instruments, talking with the family, getting meds. Your responsibility is to chart, make sure that you kind of keep a timeline of the surgery. And another big thing that I think people don't realize is that the nurse is always thinking ahead of what's going on. So you're always planning, okay, what is my next action? What is everybody else's next action? Because now I need to plan and take the next step. So that's really important.
To me, it sounds like the nurse is kind of the glue that holds the OR together.
Exactly. And, there's those times where you kind of put your foot down and stand up and say, okay, whether when people are coming into the room and if people aren't paying attention and you're ready to start your timeout, you kind of have to assert yourself and say, okay, everybody, we are starting this timeout. Let's have everybody's attention because by law, you are required to do a timeout and you are required to count. And if people aren't paying attention, it can be really easy for somebody to make a mistake. So learning to speak up, and some people sometimes are a little nervous to talk to surgeons and anesthesiologists, but you work so closely with them and the team that you have in that room is your team. And so, it's an important role for sure.
Yeah. Speaking on, you said some people are nervous around surgeon and anesthesiologists. surgeons can kind of have like a raw personality where they're just flat and real direct and to the point. I'm sure you see a different side of them to some degree in the OR. Do you have anything to say about, like, I don't know, the personality, dealing with the personalities of surgeons as a whole?
Sure. So just like outside of OR, you come across many different personalities. I've worked with surgeons who are very laid back, very understanding. They kind of just go with it. And then I've had some surgeons who are like, if it's not this, this, and this, then, you know, we're going to have a problem. Same thing with anesthesiologists and CRNAs. Some of them are more assertive and some are more laid back. One thing that's very nice is when you have surgeons or anesthesia providers who really like to teach. Because if you've never been in the OR, this is all new and it's all very overwhelming and it moves so fast. So if you have someone explaining, okay, this is what we're doing, or I need you to hold this, or connect this piece here, this is what we do, it really helps lower the anxiety and the stress. So to kind of go back to your question, I have dealt with many different personalities. Some are better than others, and the way a surgeon is in the OR is completely different when they're with the family or with Pacu. And so being an OR nurse and years, I've had the same surgeon talk to me one way in the OR and talk to me in the Pacu. I'm like, are you the same surgeon? That's a totally different personality. So yeah, I think I've seen a lot of surgeons kind of amp themselves up and prep themselves for surgery. So I think once they kind of get in the game of I'm doing this surgery, a different personality can come out sometimes.
Yeah, that makes sense. Is it a high stress work environment?
It can be. It definitely can be. So again, it does depend on the surgery and who you're working with. Because you have, so anesthesia, surgeon, the scrub tech, the nurse, and then sometimes you might have a few other people, but that's generally who's in there. If that team is more calm, the surgery typically will be less stressful. If you have more of a high-strung group of people, then that adds to the stress. And also if you have a complicated surgery, that will also add to the stress.
Okay. Let's see. Can you compare your role as in an OR versus Pacu? I think you really covered your OR role really well. Do you want to talk about the role as a Pacu nurse?
Sure. So as a Pacu nurse, that one is going to be critical care. So kind of how the flow works is the Pacu nurse will be advised that the patient's coming, so we get everything ready. They come in, and the first thing that you're doing is you're hooking them up, and you immediately start assessing them. So you cardiac, blood pressure, you know, you do all your vitals, and you start doing your head to toe so that you can really see where do I need to start working now. The main goal is that the patient safely wakes up. A lot of times you'll run into issues with people who are hypotensive, issues with like the airway spasm, sorry. And so you might have to bag them. You might have to, anesthesia is going to be there, might have to give some certain medications. And so you're basically making that safe transition. That is your role as the Pacu nurse. Then you monitor them throughout the process. Also, if there's any medications for pain, as I was told when I transitioned into Pacu, as I was told by one of the nurses, he's like, well, welcome to being a pain medication expert. That's okay, because you have so many different options, and really you learn to see like the timing of them, how they work, how they affect people, and when you add multiple ones together, what is the effect? And so, so yeah, you really do become a pain medication specialist.
In your typical ratio
for Pacu?
Yeah.
It's 2 to 1, or if you have children, it's a 1 to 1.
Okay. Good. Let's see, about how long are your patients in the PACU prior to either discharge or transferring up to the floor?
Now that can vary.
Okay.
So that really is dependent on the patient. So children, when we would do the dental, the pediatric dental, those ones were relatively quickly. I've seen it even as quick as 10 minutes. Generally, it's about typically about an hour. And then if you have other patients with, so talking about other surgeries, I mean, I've had patients there for 4 hours.
Okay.
And with, say, the adults, it's typically going to be around an hour and a half to 2 hours is going to be the time to wake up. But yeah, it's very, very different for each person.
Yeah. So what's your favorite thing about OR nursing?
My favorite thing about OR nursing, I love watching surgery, except for ortho. Ortho is my area where, I don't know, I hear the bones and I hear the drills and the saws, and I just focus on my charting during that time. but I love general surgery, gyno, all of that. It's fascinating to see the anatomy and just the body from a different point of view. You really learn a lot about A&P, hemodynamics. So just to see that is really amazing. I mean, I've held people's stomachs after they've had the gastric sleeves, the gastric bypass surgeries. I've held that in my hand, gallbladders, cysts. I mean, there's been times I have seen things come out of people's bodies, and I'm just amazed that they lived with that for so long. So that's really fascinating.
What's the craziest thing you've seen removed out of a body?
I would say, because we didn't do a lot of traumas, so not really foreign objects did I see be taken out of someone's body. But but one time there was a patient who had cysts, and I've never seen so many cysts, and the size of them was just incredible what they took out. So I couldn't even imagine how much pain that patient was in because of what we took out. Great.
Wow. And then what's your favorite thing about PACU nursing?
PACU nursing? I love, it's going to sound weird, I love watching the patients progress. I love the acuity when they come out because it's really challenging, and you always have to be on your game when they first come out, ready to handle if someone's crashing or not breathing or whatever. I love that. And then it's an interesting transition for people to wake up. It seems like it's real easy, like, oh yeah, and I would tell family members, I'm like, yeah, I just get paid to watch people sleep and wake up. But in reality, I'm doing so much more as I'm doing this. And some people wake up real nicely, and some people do not wake up nicely. Some people hit, scream, if they have other issues, like maybe they had anxiety or something that can build up, you'll have to be dealing with that. So you always have to be on your toes. And that I really love about PACU. And each surgery can be different, and the way the person comes out is different each time.
Nice. We're getting to the end of our Q&A with Tammy, so if you guys have any questions, please get them in. It does take a few seconds of lag time to transition over to us, so get your questions in before we head out, okay? Tammy, this is the last question that we have that was pre-entered. What's the hardest part of OR? And I think you already addressed that, was or least favorite part was ortho surgeries. Anything you wanted to add to that?
No, I think, I mean, with the challenges comes the good things. I mean, and each person, how they handle situations is different. So making sure, again, just learning about the OR is really, because there's so many different areas, and what one thing could be hard could be easy for another person. So just adapting to it, because it is so specific. It's unlike any other specialty that I've ever seen. So it can be challenging, and it can be high stress. So yeah. And
that's probably the same thing about PACU, just everybody's so different and every circumstance is so different. But if you have the hardest thing about PACU?
hardest thing about PACU is trying to what medications will work for the person, because you have some people who are opioid naive and some who aren't, and you're trying to control their pain, and what you know to work on one person might not work on another person. So it's really testing the waters and knowing your medication, knowing how much you're gonna give, and seeing how the person responds to it. And then you have to be ready to, if they don't do well with it, be able to respond to it. So it's that critical thinking, observation, assessment, and being right there with the patient. So that's probably the most challenging.
Okay. Heather asks, you don't transition from OR to PACU in one shift, right?
Typically, no. But there have been times. I was lucky enough, again, I worked in a smaller OR and surgical services area. So I was trained in pre-op, PACU, and OR. Also, a lot of the PACU nurses would be trained in conscious sedation. So those are all areas that you could rotate. There have been days where I was relieving people for lunches. So I was in pre-op, started in pre-op. Then I covered in the OR, so I was an OR nurse. And then I went back to PACU. So for that same patient, I was his pre-op, OR, and PACU nurse. It didn't happen very often, but it has. And I really feel that that's typically only because of the small hospital that I worked in. If keep in mind that OR and PACU are inherently completely separate specialties. But I was fortunate enough to work in this area where it allowed us to do all of them if we wanted to. So yeah.
Good question, Heather. So my last question is, I know that you've since left the OR and went on to a different specialty. Do you want to talk about like what your heart was in transitioning into where you're at now?
Sure. So the main reason why I transitioned was because of the schedule. My husband as well. So we, for our children's sake, we try to work opposite schedules. And because of my facility, we didn't have 12-hour shifts. It made it a little bit more difficult. So main reason was for the schedule. And I was actually pretty apprehensive and nervous to transition from a surgical services to, I work in progressive care now, to being on the floor, because it's so specific. And I was worried. I didn't know if I was going to be, if I had lost anything, or, you know, if it was going to come back to me, or what, because I went straight from nursing school into the OR and into surgical services area. So I was a little apprehensive about that. But one of the is I realized, making that transition, there are so many things that I learned in the OR and PACU that have helped me on the floor, that I didn't anticipate. Same thing working OR, PACU, and then getting surgical patients on the floor. I'm like, oh yeah, I know all about this. Or you know what? I've worked with your surgeon. I have seen them perform in the OR.
That's so cool.
Yeah, it was really cool, and I was able to, calm my patients more if they were worried about how it was going to be afterwards. I could better educate them about what to expect on the surgery. So that I find really amazing, and I love surgical patients. So yeah, that was. It turned out well. I really enjoy it.
That's great. And nursing is so beautiful. Like, you can do so many different things, and you just take all those skills and experience with you everywhere you go and just add to it.
Exactly. And as being a new grad, I didn't know that. And that's why I was just really apprehensive. But now that I've made that transition, I can see. And it was a good decision, and it worked out. So
that's great. Heather says that they love having you.
Oh, thanks, Heather. I work with them.
That's great. I think nurses in general are super amazing, and this whole culture of supporting each other and taking each other under our wings is really taking off, and I love to see it. So thank you for giving us your time, Tammy, and all you guys that attended and watched, thank you so much. If you have questions and you're watching this on replay, put them in the comments, and Tammy will be happy to answer them, I'm sure.
Yeah.
Have a good day, guys. See ya.
Bye.